Hello everyone, welcome to a warm-up review. Let's get going. First question here, which organelle becomes hypertrophied in hepatocytes with chronic phenobarbital use? The answer is the smooth endoplasmic reticulum. Next question, which enzyme mitigates the aging effects of cellular division by maintaining chromosomal length? The answer here is telomerase, and telomerase is that RNA protein complex that adds repeated DNA sequences to the terminal ends of the linear ends of chromosomes. Next question. What are the neural crest derivatives in each of the following adult structures? So what do those neural crests become? Well, in our peripheral nervous system, they're going to become the autonomic nervous system, like the vagus nerve and the sympathetic ganglia. You're also going to see it become the dorsal root ganglia, so sensory nerves, cranial nerves, and Schwann cells. Now, in the adrenal gland, you're going to see those become the chromaffin cells in the medulla. And then in the thyroid, you're going to see them become the parafollicular cells, also known as those C cells. All right, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to return to our old friend embryology and talk about how the brain develops and some things that can go wrong. If you remember from the Foundations 1 video, the notochord induces the ectoderm to form the neural plate and the neural crest. We talked about how that neural plate folds up and forms the neural tube, and we called that the process of neurulation. And in the early stages, this is an open tube with an opening or a pore at either end of the tube, which are called neuropores. We'll come back to those shortly. The cells lining the neural tube are eventually going to become the brain and the spinal cord, and the canal itself, the space inside the neural tube, will become the ventricles of the brain and the spinal canal. During week 4 of development, the rostral end of the neural tube, the end that will eventually become the head, will start to dilate into 3 structures that will become the brain: the prosencephalon, the mesencephalon, and the rhombencephalon. The prosencephalon is up front, so that's the forebrain, and the rhombencephalon is the hindbrain. And then at week 5, the prosencephalon becomes the telencephalon and diencephalon, and the rhombencephalon becomes the metencephalon and the myelencephalon. And then what adult structures will these eventually become? Well, the telencephalon becomes the cerebral hemispheres, the basal ganglia, the hippocampus, and the amygdala. These are the high-level structures in the brain. The diencephalon becomes the thalamus, the hypothalamus, and the optic nerves and tracts. The mesencephalon becomes the midbrain. The metencephalon becomes the cerebellum and the pons. And the myelencephalon becomes the medulla. Now, this is about a 3-star topic. You may or may not see this on your test, but if you do, you'll be glad you reviewed it. Now, let's talk about some of the things that can go wrong in this development, starting with neural tube defects. Remember we said that on the ends of the neural tube are openings called neuropores, which connect the inside of the neural tube to the surface ectoderm. In the 4th week, if the neuropores on either end of the neural tube fail to fuse so that there's a connection between the spinal canal and the amniotic cavity, a neural tube defect results. And the main risk factor for neural tube defects is low folic acid levels. If the embryo doesn't have enough folic acid at this stage of development, that can predispose to neural tube defects, which is why women of childbearing age need to supplement folic acid. Most multivitamins have 0.4 milligrams of folic acid, but some prenatal vitamins double that to at least 0.8 milligrams or even 1 milligram. Women at high risk of having a baby with a neural tube defect are recommended to take 4 milligrams per day. So if you previously had a child with a neural tube defect, then you need to supplement folic acid 4 milligrams, not 0.4 milligrams per day. To check for neural tube defects in utero, we can look at the sonogram and inspect for a defect visually, and we can also look at mom's serum with a quadruple screen, or a quad screen. If there's a neural tube defect, the maternal alpha-fetoprotein will be elevated. If the alpha-fetoprotein level is elevated, that usually would indicate one of 2 big things. One is a neural tube defect, and the other is an anterior abdominal wall defect, which will be covered in another video. In trisomy 21, or Down syndrome, the quad screen would show a decreased maternal AFP. So if you do your quad screen and there's an increase in AFP, but you can't see a neural tube defect or abdominal wall defect on ultrasound, what do you do next? Well, you can perform an amniocentesis and look for increased AFP in the amniotic fluid. And if it's also elevated in the amniotic fluid, then you've confirmed that there must be a defect. There are three main types of neural tube defects. Spina bifida occulta is the mildest form. That's where you have failure of the spinal canal to close only on the bony level. There's no herniation of the spinal cord, but there can still be some physical limitations that result from this type of neural tube defect. This nearly always occurs in the lumbosacral region, and often there's a little tuft of hair on the skin over the sacrum, which is a huge clue on your newborn exam. If you see that tuft of hair in exam, you might want to obtain an ultrasound of the region to see if the bones fail to fuse properly. The other types of neural tube defects are the meningocele and a myelomeningocele. If it's just the meninges that are herniated, we call it a meningocele. If both the meninges and the spinal cord have herniated, then it's a myelomeningocele. Next, let's talk about forebrain anomalies. Neural tube defects usually present in the lumbosacral region, but there can be problems with the neuropore at the cranial end of the developing neural tube. And that causes something called microencephaly, or the more commonly used term is anencephaly, or sometimes microanencephaly. This is where the calvarium and most of the brain fails to develop. We have an image of this, but it's a little disturbing. The neuropore fails to close, so the cranium doesn't really develop properly, and it's left open and exposed to the amniotic fluid. But there's usually some brainstem tissue. That's why this is most appropriately called microencephaly or microanencephaly. Micros is Greek for part, so part of the brain is present, but most of it is not. But obviously this is incompatible with life. And as a clinical pearl on ultrasound, these fetuses usually have polyhydramnios, or an excessive amount of amniotic fluid, because they've lost the swallowing center of the brain. Normally, the fetus is constantly swallowing the amniotic fluid and then urinating it back out. But with microencephaly, the swallowing center of the brain is damaged or absent, and the amniotic fluid keeps building up, and you'll see polyhydramnios. Another forebrain anomaly is holoprosencephaly, which we've seen once before. Remember, holoprosencephaly is where the hemispheres of the brain fail to separate across the midline. Two characteristic findings of holoprosencephaly are cleft lip and palate and cycloplegia. So the most severe example would be a single midline eye, although it might just be very close set eyes. We said this can be seen in sonic hedgehog gene mutations, severe fetal alcohol syndrome, or in Patau syndrome, also known as trisomy 13. Another group of developmental disorders are the posterior fossa malformations. So instead of forebrain abnormalities, now we're talking about hindbrain abnormalities. We call these Chiari malformations, or sometimes you'll hear them called Arnold-Chiari malformations. I won't get into the distinction between the two because it's not really important for this test. Basically, a Chiari malformation is where part of the cerebellum herniates downward through the foramen magnum at the base of the skull. There are 4 different classifications, but you really only need to focus on type 1 and type 2. A Chiari 1 malformation is the mildest form, where only the cerebellar tonsils herniate. But since you now have cerebellar tissue squished into the spinal canal, this can sometimes compress the spinal cord and lead to something called a syringomyelia. We'll cover syringomyelia in a later video on spinal cord lesions. A Chiari 2 malformation is where you have a lumbosacral myelomeningocele, and that results in a more significant herniation of the tonsils and also the vermis. So there's a big neural tube defect down low, it's lumbosacral, and it causes herniation up at the foramen magnum. But because of this herniation over time, you can see stenosis of the aqueduct and some hydrocephalus. This is an MRI of a child with a Chiari-2 malformation, and you can see that the third ventricle, marked V, is fairly enlarged. So that's hydrocephalus. There's also Chiari-3 and Chiari-4 malformations, which are progressively more severe, but again, I don't think these are likely to show up on your test. One last type of posterior fossa malformation to mention briefly is the Dandy-Walker syndrome. Basically, this is where you have an enlarged posterior fossa and the cerebellar vermis fails to develop. So the fourth ventricle dilates to fill up the space that's left. And this can be associated with hydrocephalus and spina bifida. The other major embryology topic I want to go over is the pharyngeal apparatus, because this is where several of the cranial nerves arise from. Now, I know that some of you panic when you hear the phrase pharyngeal apparatus, or you may know it by the older name, the branchial apparatus. But we're going to focus only on what you need to know for your exam, because it's really easy to get bogged down in this stuff and get confused. The pharyngeal apparatus is composed of the 6 lumps of tissue on each side, and we call the lumps of tissue pharyngeal arches. Then on the lateral sides, the grooves between the arches are called pharyngeal clefts. And then the grooves on the medial side of the arches are called pharyngeal pouches. The clefts are derived from ectoderm. You can remember that the C for clefts matches the only embryologic tissue with a C in the name, which is ectoderm. Not endoderm, not mesoderm, but ectoderm. The arches are derived from mesoderm. Remember that mesoderm bridges the gap between ectoderm and endoderm, in the same way that an arch bridges a gap. And the pouches are derived from endoderm. So endoderm on the inside, ectoderm on the outside, and mesoderm in the middle. We're going to talk about each of these in turn, starting with the clefts, because they're the most straightforward. Then we'll work our way up to the arches. So again, the pharyngeal clefts are the ectodermal portion of the pharyngeal apparatus. Let's focus on what adult structures arise from the pharyngeal clefts. The first cleft develops into the external auditory meatus. The second, third, and fourth clefts form temporary cervical sinuses that are obliterated later. And that's pretty much it for the clefts. Pretty easy. Now, if one of those temporary cervical sinuses fails to be obliterated so that it persists, the patient might be born with what we call a pharyngeal cleft cyst in the lateral neck, which is found under the skin. Another type of neck cyst that you might see is a remnant of the thyroglossal duct, which is formed when the thyroid gland slides down from the base of the tongue into its final position in the neck. That thyroglossal duct is normally obliterated, just like the second, third, and fourth pharyngeal clefts. But if it persists, we call it a thyroglossal duct cyst. And the reason I bring this up is that if you're given a patient with a cyst in the neck, you need to be able to distinguish between a thyroglossal duct cyst or a pharyngeal cleft cyst. So here are a couple of clinical clues. First of all, the location. Pharyngeal cleft cysts are located in the lateral neck, where the pharyngeal apparatus was. And where's the thyroid? In the midline. So a thyroglossal duct cyst will be located in the midline. The second clue is whether or not the cyst moves when you have the patient swallow. A pharyngeal cleft cyst does not move when you swallow, but a thyroglossal duct cyst is pushed around by the thyroid cartilage, so it does move with swallowing. So make sure you can tell those two apart. That's very important to know for your test. So the clefts are pretty easy. Now let's talk about the pharyngeal pouch derivatives. Remember, the pharyngeal pouches come from endoderm. The first pouch will become the middle ear cavity, the eustachian tubes, and the mastoid air cells. So the first cleft became the external auditory meatus, and the first pouch becomes all these middle ear structures. That makes sense. The second pouch gives rise to the epithelial lining of the tonsils. the third pouch becomes the inferior parathyroid glands and the thymus. And then the fourth pouch becomes the superior parathyroid. So the third pouch structures are actually inferior to the fourth pouch structures, which seems a little strange. But take note that the third and fourth pouches give rise to the parathyroid glands and the thymus. This is clinically relevant because of something called DiGeorge syndrome. DiGeorge syndrome is an immunodeficiency syndrome, which we'll talk about during immunology. In DiGeorge syndrome, you don't have normal development of the third and fourth pharyngeal pouches, so you won't have a thymus or parathyroids. Without a thymus gland, the T cells can't mature, and that causes the immunodeficiency part. And without the parathyroid glands, the patient gets hypocalcemia. So for DiGeorge syndrome, you need to remember thymic aplasia, T cell deficiency, and hypocalcemia. Now, let's roll up our sleeves and get after these pharyngeal arches. Again, the pharyngeal arches are mesoderm-derived structures. And the good news is that even though this is pretty complicated, you don't need to get too bogged down in these. Mainly, I want you to know a handful of quick mnemonics and associations that we're going to go over. Each pharyngeal arch has a cartilage, which becomes bony structures, a muscle component, and a nerve. It also has an artery or an aortic arch, and we're going to talk about those in the cardiovascular section. Starting with the first pharyngeal arch, I want you to remember that the first arch gives rise to M and T structures. You start with Meckel's cartilage, which gives rise to several jaw structures, the mandible, the mandibular ligament, and also the malleus and the incus. Remember that the first cleft and the first pouch were associated with the ear, and here the first arch is forming the ossicles of the middle ear. And maybe remember that the ossicles are derived from neural crest, which is ectoderm, not mesoderm, while the mesoderm of the pharyngeal arches gives rise to the muscles and other structures, but the bones and cartilage come from neural crest cells, which have migrated here. For the muscles, again, think about the jaw, and you have the muscles of mastication, including the masseter, the medial pterygoid and lateral pterygoid, and the temporalis muscle, which is one of the T structures. Also the mylohyoid muscle, and then some more T's, the tensor tympani, the tensor veli palatini, and the anterior 2/3 of the tongue. And the nerves that innervate these structures are the mandibular and maxillary branches of the trigeminal nerve. So lots and lots of M's and T's. And if the first arch neural crest cells fail to migrate, you get another T word, Treacher-Collins syndrome, which is a series of facial abnormalities that you don't really need to memorize for step 1. Step 1 won't expect you to distinguish the differences between facial features of different genetic disorders. But if you're curious, you can find images of Treacher-Collins syndrome on the internet. Basically, these individuals have an underdeveloped mandible and underdeveloped cheekbones. For the second arch, you can remember that the second arch gives rise to the S structures, the stapes, which is another middle ear ossicle, the styloid process, the stylohyoid ligament, and the double S in the lesser horn of the hyoid. The nerve that innervates the second arch muscles is cranial nerve 7, another S. And you know that cranial nerve 7 is the facial nerve, which innervates the muscles of facial expression. So for the muscles derived from the second arch, you have the muscles of facial expression, even though they don't start with S. And then also the stapedius and the stylohyoid, which are back to the S's. And then the possible congenital abnormality here is the pharyngocutaneous fistula, which is a fistula between the tonsillar area and the cleft in the lateral neck. And we also talked about how persistence of this cleft can lead to a pharyngeal cleft cyst, a lateral neck cyst that does not move when you swallow. For the third arch, the quick association is the word pharyngeal. know that the third arch muscle, the stylopharyngeus, is innervated by a branch of the glossopharyngeal nerve, cranial nerve 9. For arches 4 and 6, think about the words cricothyroid and the larynx. You've got the cricoid cartilage, the thyroid cartilage, and the rest of the cartilages of the larynx, arytenoids, corniculate, cuneiform. And for the muscles, there's the cricothyroid muscle, which comes from the 4th arch, and the rest of the laryngeal muscles come from the 6th arch. 4th comes before 6th, so 4th gets to choose first. The 4th arch also develops into the pharyngeal muscles, which are involved in swallowing. And since we're talking about the 4th and 6th arches, 4 plus 6 gives you cranial nerve 10, or the vagus nerve. The superior laryngeal branch of the vagus innervates the muscles that came from the 4th arch, the muscles involved in swallowing. And the recurrent laryngeal branch of the vagus nerve innervates those laryngeal muscles that came from the 6th arch, which are needed for speaking. And then, what about the 5th arch? Did we skip that? No. The 5th arch basically recedes and makes no major developmental contributions. So again, to help you remember the structures, the 1st arch is the M's and T's. 2nd arch is the S's. The 3rd arch is the word pharyngeal. And the 4th and 6th arches are the words cricothyroid and larynx. All right, that's enough embryology for now. Let's pause the video and complete the end of session quiz, then we'll talk through the answers. All right, let's go through these together. First question, what abnormalities are often found with a Chiari malformation? We said a Chiari 1 malformation can lead to a syringomyelia, and a Chiari 2 malformation can be associated with a myelomeningocele, and it can lead to hydrocephaly. Next question, what amniotic fluid lab abnormality might point you to a diagnosis of anencephaly? You'll most likely see an increased alpha-fetoprotein in the mom's serum and in the amniotic fluid, because anencephaly is a type of neural tube defect. And lastly, from which pharyngeal pouch is each of the following structures derived? Middle ear and eustachian tubes are from the 1st pharyngeal pouch. Superior parathyroids are from the 4th pouch. Inferior parathyroids are from the 3rd pouch. The epithelial lining of the palatine tonsil is from the 2nd pouch, and the thymus is from the 3rd pouch. All right, that's it for this video. See you next time.